Hello guys, my evidence-based project was on treatment for major depressive disorder. Um, Major depressive disorder affects about 5 to 10% of the population of the world, and it is known as the most common mental health issue around the world. In the United States alone, 3 to 5% of male and 8 to 10% of females are depressed. And however, in order to diagnose major depressive disorder, we have to look for at least five factors according to Amini et al. One, the feeling of anxiety, irritability, hopelessness, and dysphonia. Two, thought disturbance characterized by guilt, inability to focus, and preoccupation. Three, cognitive decline, as seen in frustration, negative connotation, indecisiveness, or lack of focus or memory. Four, physical illness accompanied by sleep and appetite disturbance, sexual dysfunction, and the last category, but not least, is failure in life's endeavors, such as personal life, unstable interpersonal relationships, and personal life balances. Who is at risk of a major depressive disorder? Now, patients who have suffered any recent trauma, chronic pain, patients with a family history of major depressive disorder, patients who have had a history of substance abuse or who are currently abusing substance, alcoholism, illnesses like diabetes, CVA, MI, or osteoarthritis, chronic insomnia or fatigue. Such patients would often show symptoms of this disease. Now, treatment for major depressive disorder, we could treat it in two ways. We could either use pharmacotherapy or psychotherapy. Now, with pharmacotherapy, SSRIs are often the first line of drugs considered. In this group, we have drugs like sertraline, fluoxetine, or Celexa. We also use TCAs like amitriptyline, or MAO inhibitors, or lithium. In the non-pharmacological category, we have cognitive behavioral therapy. This therapy is used to help modify a patient's thought process and focuses on social skills and problem solving. Now, for this to be evaluated, at least 8 to 12 sessions must be done to determine effectiveness or not. Now, supportive and interpersonal psychotherapy helps with problem solving and reinforcement of social skills. Usually, progress is seen between 12 to 16 sessions. Now, we could also use ECT. ECT is used mostly in patients who have psychotic and as well as you see psychotic symptoms as well as suicidal ideations, where other therapies have proven to be ineffective. Now, how ECT is done, the first 3 treatments are done every other day, and subsequent ones are done twice a week, with progress noted within 6 to 12 sessions. Other methods that does not require pharmacotherapy is lifestyle changes. How a person can change the lifestyle to help affect and change moods is through healthy eating and exercise, adequate sleep and hygiene, stress controlled, and involvement in leisure activities. And then in leisure activities, disease from substance abuse, mood change records should be kept. And then now the first case study, this qualitative study focuses on the experience of patients in Iran with major depressive disorders. In this study, the researchers interviewed 18 patients and the verbatim transcript of the interview was analyzed. Though the study revealed the challenges of working with patients with major depressive disorder, it also revealed the limitations of dealing with the cultural aspects of care of the depressed individual. Now, the standard of care was based in just the provision of medications based on the above symptoms. However, it became clinically relevant for healthcare workers, especially the nurses, to incorporate cultural aspects of care through constructive listening to the patients and thereby building trust while working with major depressive disorder patients in a very non-judgmental fashion. Future research is still needed to find out the correlation between religion and this disorder. The second study. In this study, the researchers focused on the influence of plant behavior in patients with modified depression disorder. Now, with regards to placement in rehab facilities by rehab workers. Now, a major depressive disorder placement scale was created to investigate this. The sample for this study was taken from 180 rehab placements in the mid-Atlantic region of the US, and a 13-item assessment on the questionnaire was evoked based on 3 characteristics of rehab placement professionals: subjective norm, attitude, and perceived behavioral control. The limitations of this study stems from the rehab professionals' inabilities to stabilize the patient with major depressive disorder with regards to their driving force or motivation to pursue employment. It is therefore imperative that for future rehab professional counseling, the correlation between the subjective norm, attitude, and behavioral control therapy be made known prior to the rehab counseling or consultation for employment. The third case study was a case study in this study where pregnant women with major depressive disorder preferred treatment with psychotherapy versus pharmacotherapy. Unfortunately, psychotherapy is not often the route chosen by most due to logistical barriers such as traveling time to and from counseling sessions, as well as the cost of such therapies. Now, computerized assisted behavioral therapy in the study, the method was used with 10 pregnant women who suffer from chronic major depressive disorder. The result was alarmingly successful, with 8 out of 10 participants responding well to treatment and 6 out of 10 with remission seen after barely 8 sessions of the computerized assisted behavioral therapy. The limitation of this study proved that it will only benefit those with the time and the financial means to do so. It could be suggested that the computerized cognitive behavioral therapy be customized based on the patient's means. We're talking about the patient with major depressive disorders means, that is, or resources. This is because, though effective, as seen above, not every patient has the logistical considerations necessary to afford this type of care. Now, the fourth study, in this study, the researchers did a double-blind study and used a placebo-controlled clinical trial study aimed at assessing the effectiveness of Prestige when administered to perimenopausal and postmenopausal women suffering from major depressive disorder. They used 40 perimenopausal women in a blind study and 70 in a placebo-controlled clinical trial, postmenopausal women diagnosed with major depressive disorder. Now, where patients were administered in the range of 100 to 200 milligrams per day of Prestige for the women who were in perimenopausal, and 50 milligrams of Prestige placebo for 8 to 10 weeks, respectively. Now, for the 798 patients used this medication, it was concluded that Prestige was effective in treating major depressive disorder in both peri or postmenopausal women. The limitation of this study, as pointed out by the FDA, stated that the clinical data was insufficient, and though this drug has not yet been approved for this subgroup of peri or postmenopausal women, it could still be prescribed in patients with major depressive disorder, adult patients with major depressive disorder. In conclusion, therefore, the treatment for major depressive disorder has to be monitored, and in monitoring, we have to review and adjust medications as needed, and this can be done within a 3 to 4 week period with follow-up visits. Should be at least twice in a 12-week period. Continue antidepressants for at least 6 months to 2 years, depending on the risk of remission. Antidepressants should be tapered down and not ever stop abruptly. Thank you.